Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Imagine facing a diagnosis like pancreatic cancer. Time feels incredibly compressed, doesn't it?
It really does. Every single moment counts.
You absolutely need to know and know quickly if the treatment you're starting is actually doing anything. But right now, the standard ways, well, they involve waiting weeks, sometimes even months, for imaging results, computed tomography scans.
And these scans, they aren't always straightforward to interpret.
Right. Especially with some of the newer treatments, the immunotherapies, where things can look worse before they get better, that pseudo-progression thing.
Exactly. Pseudo-progression, it complicates the picture significantly.
Yeah.
And then you've got the standard blood marker, CA19-9.
Yeah. But that's not useful for everyone, is it? I read that not all tumors even release it.
Precisely. So it leaves a big gap for a lot of patients. Doctors and patients are stuck in this kind of holding pattern.
And with pancreatic cancer, that waiting time is just...
Yeah.
It's incredibly precious time you might not have.
That's the crux of it, that urgent need for speed, for clarity. It's exactly what researchers are tackling.
I saw a quote from one of the senior authors on the research we're looking at, Dr. Velculescu.
Yes, Victor Velculescu. He put it very plainly. The goal is simple. Know ASAP if the therapy is working.
Because if it's not...
You need to switch fast. You can't afford to waste months on something ineffective.
Okay, so that perfectly sets the stage for the really fascinating work we're diving into today. We've got insights from a health news piece and a detailed scientific paper.
And they're exploring a really different angle on this monitoring problem.
So our mission today is really to break down these sources, right?
We want to explore how analyzing just a blood sample using some pretty smart tech, including artificial intelligence, might give us that faster, maybe simpler, and hopefully more reliable way to see how pancreatic cancer is responding.
Faster, simpler, more reliable. That sounds like the goal. Okay, let's properly get into the challenge itself. We know pancreatic cancer is urgent. We know imaging has limits. CA19-9 has limits.
Right. The delays with imaging, the potential for misinterpretation, especially early on with immunotherapy, that's a huge hurdle.
And the CA19-9 protein marker just isn't universal. Doesn't help if your tumor isn't making it.
Exactly. So the hunt has definitely been on for something better, something less invasive, maybe.
And something that gives a clearer picture faster, like a real-time view of what the cancer's doing.
And that's really where this idea of liquid biopsies comes into play.
Liquid biopsies. So not needing a chunk of the tumor itself.
Correct. You analyze bodily fluids, usually blood, and the focus here is specifically on something called cell-free DNA.
Cell-free DNA. Okay, what is that exactly?
These are tiny little fragments of DNA. Your normal cells shed them, but importantly, cancer cells shed them too, right into the bloodstream.
Ah, okay, so the cancer's DNA is just floating around in the blood.
In fragments, yes. And the idea is that by analyzing the cell-free DNA, you could potentially get a snapshot of the cancer's state without needing an invasive biopsy, just from a blood draw.
That sounds incredibly powerful.
Yeah.
So how did the researchers in these studies actually analyze this cell-free DNA? I gather there were two main approaches.
Yes, two distinct methods they evaluated, both using whole genome sequencing, which means looking across the entire DNA landscape.
Okay, what was the first one?
The first is called whole genome mutant allele fraction. Let's call it WGMAF for short, though you asked for no acronyms. Maybe just mutant allele fraction.
Let's stick with the full name, maybe. Whole genome mutant allele fraction. Sounds complex.
It is quite personalized. It needs a critical first step. You must have a piece of the patient's actual tumor tissue first.
Okay, so you need that initial biopsy.
Yes. You sequence the DNA from that tumor to find its specific, unique genetic mutations. Think of them like spelling errors unique to that cancer.
Got it. Find the typos in the tumor's instruction book.
Exactly. Then you take the blood sample, sequence all the cell-free DNA floating in it, and specifically hunt for those exact same mutations, those typos, that you already know are in the tumor.
So it's tracking known errors from the tumor in the blood. Tailored, but yeah, it depends entirely on having that tumor sample.
Correct, which can be a limitation.
So what was the other approach? The one that's maybe more broadly applicable?
That one's called ARTEMIS-DELFI, and it is fundamentally different. It's designed to be tumor-independent.
Tumor-independent, meaning no biopsy needed beforehand.
Precisely. You don't need prior knowledge of specific mutations. It doesn't require that initial tumor tissue analysis.
Okay, so how does it work then if it's not looking for known mutations?
It takes a different tack. It analyzes patterns across the entire genome within the cell-free DNA. It uses artificial intelligence to look at things like how the DNA fragments are broken up, their size and distribution, called fragmentation profiles.
Fragmentation profiles, like the patterns of how the DNA is chopped up.
Exactly. And it also looks at patterns in repetitive sequences of DNA spread throughout the genome. It's analyzing the overall characteristics of the DNA fragments in the blood.
That's fascinating. So if the first method hunts for specific known words, this one is like analyzing the font, the paragraph structure, the layout, maybe how often certain phrases appear across the whole book without knowing the exact story beforehand.
That's a really good analogy, actually. ARTEMIS-DELFI is looking at broader features. These fragmentation patterns, for instance, can reflect how the DNA is packaged inside the cancer cells, the chromatin structure, and how chaotically the cells might be dying and releasing DNA.
And the repetitive elements.
Changes in patterns there can signal widespread instability or alterations across the genome. So it gives you this biological signal about the cancer's activity without needing to pinpoint individual mutations first.
Okay, much broader view. Now, these weren't just concepts, right?
Yeah.
They tested these in actual clinical trials with patients.
Absolutely essential. The main study they focused on was the CheckPack trial.
CheckPack. And who was in that trial?
These were patients with metastatic pancreatic cancer, so it had already spread.
Yep.
And they'd already had some chemotherapy.
Okay.
They were then treated with immunotherapy nivolumab, either alone or with another drug called ipilimumab plus radiation. And crucially, blood samples were collected before treatment started and then at different times after, particularly around the 8-week mark.
8 weeks. That seems like a key time point.
It is often when they do the first imaging scan to assess response, but they also took samples earlier for some patients, even as early as 2 weeks in.
2 weeks, okay. And was there another group to sort of confirm the findings?
Yes, they used data from the PACTIO trial as what's called an independent validation cohort.
Paxio.
Right.
Different patients.
Yes. These patients also had advanced pancreatic cancer, but they had not received prior chemotherapy. They got a different chemo regimen, gemcitabine and nab-paclitaxel, sometimes with another drug, tocilizumab.
Okay. And blood samples taken similarly.
Yes, at intervals, again, around 8 weeks, and also earlier for some, around 4 weeks in this case.
4 weeks, got it.
And a really important point about PACTIO, they did not collect tumor tissue from these patients.
So that makes it a perfect real-world test for the ARTEMIS-DELFI method, the one that doesn't need the tumor biopsy.
Exactly. It tested if that tumor-independent approach really worked when no tumor data was available.
Okay, the stage is set. 2 tests, 2 trials. What did they actually find? Did these blood tests work?
The results were, well, quite promising. Both methods, the whole genome mutant allele fraction and ARTEMIS-DELFI, showed that the scores measured after treatment started around that 8-week point were significantly linked to patient outcomes.
Outcomes like how long people lived.
Yes, specifically progression-free survival, how long until the cancer got worse, and overall survival, how long patients lived in total.
And how did the scores relate? Lower scores meant better outcomes.
Generally, yes. Patients whose blood tests showed a lower score, indicating a better molecular response to the treatment, lived significantly longer.
How significant are we talking? Do you have any numbers?
Yeah, they reported some striking differences in the CheckPack trial. For the whole genome mutant allele fraction test, responders lived a median of 319 days overall, compared to just 126 days for non-responders.
Wow, more than double.
And for ARTEMIS-DELFI, the responders in CheckPack had a median overall survival of 233 days versus 172 days for non-responders. Still a very meaningful difference.
Those numbers really drive home the potential, being able to distinguish those groups.
And here's a critical finding. At that 2-month mark, these cell-free DNA tests were actually better at predicting how patients would do than the standard tools used at the same time, like the imaging scans or the CA19-9 marker.
Better than the standard of care at predicting outcome.
At that specific time point, yes, according to their analysis. And when they compared the 2 new tests directly,
Which one came out on top?
ARTEMIS-DELFI seemed to be the stronger candidate overall, mainly because it was simpler, no need for that tumor biopsy up front, making it potentially usable for many more patients.
And did it hold up in that second trial, the PAC2 trial?
It did. The link between the ARTEMIS-DELFI score and patient survival was successfully validated in PACTO. This really boosted confidence in the test, especially its ability to work without needing tumor tissue data.
Okay, predicting response at 2 months is definitely valuable, big step up. But I remember reading something about predicting failure even faster, the fast fail idea.
Yes, this is potentially even more impactful. They specifically looked to see if ARTEMIS-DELFI could identify patients whose treatment was likely doomed to fail, but really early on.
How early?
After just one cycle of treatment, that meant around 2 weeks after starting treatment in the CheckPack trial and around 4 weeks in the PAC2 trial.
2 to 4 weeks. That's incredibly fast.
Yeah.
Could it actually predict failure that soon?
It seems so, and quite powerfully. Patients who had high ARTEMIS-DELFI scores at these very early time points, indicating a poor molecular response right out of the gate, had significantly shorter survival times, both progression-free and overall.
How much shorter?
The numbers are quite stark. In CheckPack, those with high scores at just 2 weeks had a median overall survival of only 110 days. Compare that to 230 days for those with low scores at 2 weeks.
Goodness. Less than 4 months versus over 7 months.
And in PAC2, high scores at 4 weeks correlated with a median overall survival of 151 days versus 280 days for those with low scores.
Again, almost double the survival time predicted just weeks into treatment based on this blood test.
It's a dramatic difference. Think about what that means. Identifying within weeks patients who are unlikely to benefit from their current therapy.
You could save them months of undergoing a toxic treatment that isn't working, months of side effects, and give them the chance to switch to something else much, much sooner.
That's exactly the potential power of this fast fail signal. Making that critical decision to change therapies earlier could preserve quality of life and potentially extend overall survival by getting patients onto effective treatment faster.
So, circling back to why ARTEMIS-DELFI looked particularly promising, it really hinges on that tumor-independent aspect, doesn't it?
That is its major advantage over methods like the whole genome mutant allele fraction. Requiring that initial tumor biopsy just isn't always practical. Sometimes the biopsy fails, or there isn't enough tissue, or it's too risky to get one.
Right.
ARTEMIS-DELFI bypasses that bottleneck. It can be used right away with just a blood draw, as long as there's detectable cell-free DNA.
And it works by looking at those broader patterns.
Exactly. The fragmentation, the repeat elements, it's capturing this sort of global signature of the cancer's activity, reflecting its genetics, epigenetics, how its DNA is packaged, without needing to know the specific mutations first.
It sounds like a much more accessible approach for routine clinical use.
That seems to be the hope. It's a different way of looking at the problem, and one that might fit better with the day-to-day realities of treating patients.
It all sounds incredibly positive, almost revolutionary for pancreatic cancer monitoring. But like all research, there must be limitations, right? The studies weren't perfect.
No, and the researchers are upfront about that, which is good science. They acknowledge that the number of patients in these trials, CheckPack and PAC2, was limited. Relatively small groups.
Okay, so need bigger studies. What else?
Another important point is how they defined responders versus non-responders based on the test scores. Those specific cutoff points weren't predefined before the study started. They were determined based on the results they saw in these patients.
So they found the best dividing line after seeing the data.
Essentially, yes. Which means those cut points really need to be tested and confirmed in new independent groups of patients to make sure they hold up and weren't just specific to these initial trials.
Makes sense. Lock down the rules before you apply the test widely.
Exactly. So more studies, larger cohorts are definitely needed to validate the findings, refine the methods, and establish those thresholds robustly. They also suggest exploring if ARTEMIS-DELFI could work for other cancers too.
Right. See how broadly applicable it is. Okay, so if we were to boil this all down, what's the main takeaway from our deep dive today?
I think the core message is that this approach, ARTEMIS-DELFI, using AI to analyze these global patterns in cell-free DNA from a blood test, shows really significant promise.
Promise for what specifically?
For figuring out much faster and potentially more accurately than we can now, whether a particular treatment is actually working for a patient with pancreatic cancer.
And the impact of that. Just imagine it for a moment. You save patients that precious time, you avoid therapies that aren't helping, you spare them unnecessary side effects.
And you empower doctors to make smarter decisions about switching treatments way earlier in the process. It could really shift how monitoring is done.
It feels like a step towards truly responsive cancer care.
Yeah.
Adapting treatment based on what the tumor is doing in real time, just from a simple blood test.
That's the vision, I think. Using these signals from the blood to guide therapy more dynamically.
So this leaves us with a really important question, something for you, the listener, to think about. If a blood test analyzing these subtle DNA patterns can give such fast, accurate feedback for a tough cancer like pancreatic, well, how else could this kind of technology reshape how we track and treat potentially many different cancers down the road?
And maybe just as importantly, what are the next crucial steps? What needs to happen to take this exciting potential from these clinical trials and actually get it into the hands of doctors and patients who desperately need better options?
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.